Hello, my name is Keisha Marshall Huling. I am a student at Columbus State University, and I am getting ready to give my presentation with decreasing falls with injuries in long-term care facilities. Populations of long-term care facilities are increasing. Falls are a big problem in these facilities. Falls with injuries are increasing and becoming a problem. This project will show that with proper planning, assessing, and interventions will result in falls with injuries. The falls are becoming a big problem in facilities because it increases the hospital rate of patients having to go in and out of the hospital for falls and with injuries. There are 1.7 million people 65 or older living in long-term care facilities, and there are 15,700 long-term care facilities in the United States, and these numbers are steadily increasing. What is a fall? A fall is unintentional coming to rest on the ground, floor, or other lower level, but not as a result of an overwhelming external force. Meaning, a fall is when you fall, not meaning to fall, not when someone pushes you. If someone pushes you and you fall, that is not considered a fall. That is an overwhelming external force. Falls with injuries. Falls with injuries result in isolation, depression, disability, and even death. Meaning, if a patient falls, if they break their hip, they're being isolated because they have to stay in their room and can't get up. And that would turn into depression. And then the depression, with the isolation of broken hip, they may become more disabled. And sometimes when a patient falls, they may even cause death because they may have a clot or something that comes from the broken bone. Falls with injuries result in poor patient outcomes, meaning that the patient decreases in their ADLs, they may become depressed, they may even die. How and why falls happen? There are many reasons why falls may happen. There are health problems. A patient may be sick, may be weak. This causes the patient to not be themselves at this time and may cause a fall. Recent surgeries or even illness may cause a fall. Chronic conditions may cause falls like hypertension. Hypertension, your blood pressure may go up. If your blood pressure goes up, then you may be dizzy. Then you may have to increase your medication, which may cause dizziness and affects your body differently. Diabetes. Diabetes may be a reason a person falls if their blood sugar drops. Mental cognitive issues like dementia. With the elderly population, dementia is a diagnosis that has been steadily increasing. Alzheimer's has been steadily increasing, and schizophrenia. With schizophrenia, you're hearing voices, or your mental state is not like it usually is, and you may misjudge where you are, and you may have a fall. Mobility causes of falls, like impaired mobility, meaning that you may fall because you're not able to walk the way you used to walk. You may be weak. You use a wheelchair, a walker. Muscle weakness or gait problems may be a reason that you may have a fall. Medication. Medication, there may be a side effect of your medication and increases patients' risk of falling. Drugs may affect the central nervous system, and with medications, they have many different side effects. They may make you weak. May make your blood pressure go up, and they may cause a fall. Environmental hazards, wet floors. How many times have you went into the kitchen and your floor is wet and you may slip? Poor lighting, you may not be able to see where you're going and bump into something. And you bump into a chair and that may cause a fall. You may misjudge your bed height. If the bed is too high for the patient when they're transferring themselves in, they may slip off the bed. Improper fitting on regular wheelchairs. Wheelchairs, even though you may be using a wheelchair, if the seat is not properly fitting in the wheelchair, it may break, it may fall. If the back is not properly proper in the wheelchair, you may fall. Foot care. Improper foot care and improper fitting shoes may cause falls, meaning if your shoes are not tied, that may cause a fall. If your shoes are too small, if the soles of your shoes are scrubbing and you trip and you may fall. Routines. A new admit comes into your facility. Automatically, their routines are changed because you have staff coming in telling them when to get into bed, when to get out of bed. This patient may like to go to bed early, and no one's there to help put them in the bed. So of course, this elderly patient is going to look at you and think to themselves, "Well, I did it at home. I may be able to put myself in the bed." So then this patient gets up, try to transfer themselves in the bed, and they're not as strong as they used to be because they're sicker and they're weaker, and that may cause a fall. The new patient may be in a different surrounding area. Like if he's at his home, his bed may be in a different place, or his chair may be in a different place, and this may cause a fall. And then meal times. How many of us eat at the same time every day? But with elderly patients, they're in a different environment and they have structured meal time. But then if you're thinking about whether or not you were still at home, you may get up and you may trip and you may fall. In elderly patients admitted to long-term care facilities, do fall interventions compared to no intervention decrease falls with injuries? And this is the question I want to answer with my plan that I want to put in place. I want to find out if I put interventions in place with a patient, will it decrease a fall with injuries compared to those that do not have interventions? Meaning, if I assess my patient and see where they're weak at, if I put an intervention in place, will that help the patient if she does fall? If he or she falls, would that decrease the falls with injuries? What can be done to prevent falls with injuries? There are many things that can be done to prevent falls with injuries. Assessment, new admits, meaning assess patients for fall risk. When that patient comes in, you go in the room and you look at the patient and you decide whether or not this patient may be a fall risk. You look at the routines. You ask the patient what were his routines before, or either ask the family members if the patient is unable to ask, what did this patient like to do? For instance, we've had patients before that have worked second shift all their lives, 3 to 11. And we coming in trying to change the way they're living. For instance, for breakfast, this patient may never have eaten breakfast. So what you would do, you let this patient sleep till he or she decides that they want to get up. And when that patient decides to want to get up, then you eat, then you feed them. So you need to find out what routines this patient had before they come into the facilities. Medication. Medication, you look at the medication this patient is taking to make sure that the medication is right for this patient, whether or not this medication is making this patient weak or dizzy. And mobility. See what the patient used prior to coming to the facility. Did the patient use a cane? Did the patient use a walker? What did the patient use for mobility before he came into the facility? Then we try to make sure that patient has that wheelchair or cane for mobility to help them transfer or help them with their routine in the facility. Assessment. Patients that are already admitted to the long-term care facility, you have to assess them too periodically to check for things that may cause them to fall, like the environment in their room. We have patients that have been in the facility for a long time that have accumulated a lot of things in their rooms. So you have to go in and rearrange, make sure they don't have anything in a way that they may trip over. You look at their medication also. And then patients, they rarely stay the same. So a patient may be sick, they're maybe cognitively declining. Interventions. Place interventions in place if a patient has already had a fall. Meaning, if a patient has already fallen out of the bed, you look at that patient and make sure that things are in place for him. So if the patient has already fell like on the right side of the bed already. So what you do is you put a mat on the right side of the bed. So if the patient falls again on their right side, they'll have a mat there to prevent those falls. So this will decrease injuries in patients if they fall again. So if you already know they've fallen before, you put this intervention in place, and then when they fall again, they won't have an injury. Intervention. Safety devices for patients. Restraints. We don't like to restrain people because it restricts their freedom of movement. But sometimes a restraint is needed to help a patient remember not to get out of their chair without assistance. A patient may lean forward in a wheelchair because of their cognitive decline or their health decline. So you may have to have a vest to put them back in the chair to keep them from falling out of the chair. And for instance, a chair alarm. A chair alarm that you may put it on the bed, or even a bed alarm. You put the chair alarm on the chair. Sometimes when the patient moves, the alarm goes off, and that'll make the patient realize to sit down and not get up. And also, it'll make the staff realize that the patient is trying to get up, and they can go in there and check on the patient and assist the patient for things that they need to be doing. Medication. Assess new admits medication and new orders for patients already admitted, meaning when you have a new patient that comes in, you look at their medication and see if this medication, do they have enough medication, or is the medication too strong for this patient that they may cause them to fall when they get up, may cause dizziness, may cause weakness. And then when an old patient that's already been in the facility get a new order, you need to look at that medication also and make sure that the milligrams are okay, or if the patient has been acting differently since they've been taking this new medication. Because sometimes you have to readjust and adjust patients' medication for them. So then after we've talked about all these, I'll get together a fall management team. And with this fall management team will consist of the administrator, a representative from nursing, a representative from the dietary department, a representative for housekeeping, social, activity, and maintenance. And everybody plays an important part in the well-being and care of a patient in the facility. Meaning, for instance, maintenance. Maintenance have to make sure that the wheelchairs are properly in place, the environment is fine in the room, the beds are functioning. Activities. The activity person provide activities for their patient to keep them busy, to keep them trying to get up by themselves, and for assistance. Social helps get the routine of the patient, talks to the family members to see what the patient like to do prior to coming to the facility. And then with housekeeping, when they mop the floors, they got to make sure the floors are mopped properly. They have to make sure the wet floor signs are down, make sure there are no spills. Dietary have to make sure the patients are fed properly, they're nourished, and for instance, they have diabetes, they have to make sure they're getting the right diet. And nursing has to assess the patient and make sure that they all the things that everybody else is doing is coming into place. And the administrator is the head, and they make sure that we are in this meeting and all things are taking place that are legally correct. The focus of the team would be weekly meetings, meaning that we'll pick a day out of the week to have a care plan meeting. And with this meeting, we will bring in all the falls that have happened during the week from the last meeting. We would talk with all the people that's in on the IDT team to input on why that patient failed, to see could the patient tell you why they failed, and was it the environment of the wheelchair, improper shoes, or medication. Then we assess everything that we've talked about from why the patient failed, and then we'll place interventions in place. And then after the interventions, we'll have the planning. The care plan is how the patient is being taken care of. So in the care plan, you have the interventions, you have your goal, and you have the problem. All intervention will be placed on the care plan so nursing staff can help decrease falls with injury. Meaning, a CNA can go get their care plan and see how they're supposed to take care of the patient. And then make sure that they have all their proper safety gear, make sure the wheelchair is working properly, and make sure, for instance, if we have a patient that's supposed to go to bed after meals because they've fallen after every time they eat, then that nursing staff will know to go get this patient and make sure she's laying down after she gets through eating. Personal obligation. The personal obligation I have is commitment to the job and the nursing oath that I took to take care of my patients. Help other IT members to embrace change, meaning a lot of people don't like change. So we may have maintenance that doesn't want to come to the meetings because they have something they have to fix. So I have to encourage all the IDT members to know that they need to be in this meeting. And I attend meetings myself. I cannot plan something and then do not come to the meeting. And make sure interventions are carried over to care plan and implemented. So I got to make sure that after we have talked about things in the meeting, I have to make sure that I take these interventions that we talked about and discussed and decide what we're going to do for the patient and put on the care plan and implement them and make sure that these things are happening. I want to help my facility decrease falls with injuries and provide better patient outcomes. Meaning better patient outcomes make the patients happier, they won't be depressed, they won't be isolated, and they won't be disabled. And I want to thank everyone for coming to listen to my presentation. of decreasing falls with injuries in long-term care facilities.